Thank you so much for the introduction. So Kim and I will switch off throughout the presentation, but you'll have me first. So my name is Tala, and we're going to be talking to you today about Beyond the Binary Gender Inclusive Genetic Services. And I also use she, they pronouns. So here we are in our Twitter bios or our Twitter handles underneath. And neither of us have any conflicts of interest to disclose. So before I begin, I really want to establish the space. And I want folks who are here to be open. You're here to learn. Of course, this is a conference and you're here to learn more things and just engage with new ideas if you haven't heard a lot of the things we're going to be discussing today. Just a reminder to be respectful, especially when asking questions and when using the chat room. And just be mindful that colleagues and other folks at this conference can be gender diverse too. And so just being mindful of the way you phrase things. Self-correct, so if you use the wrong name or pronoun or term, that's okay. We all make mistakes, but just apologize, correct yourself, and move on. And then lastly, assume good intention. So again, we're all here to learn, we're all here, and we may have different experiences, beliefs, customs, but we're all coming together for this educational session. With that said, we also, of course, don't tolerate transphobia, homophobia, or racism. Great. So to start the presentation, what I really want to do is root us in the history of this work and this movement. So there is a large and powerful history of trans resistance. These 4 events that I've highlighted here are some of the protests trans women of color, most often Black trans women, have led in order to demand their rights, as it was and still is being systematically taken from them by institutions, laws, the police. And it's really important that as we're talking about gender diversity and gender liberation, that we're grounding ourselves in their resistance and their work when we talk about this. And on a similar note, we want to ground ourselves in the history of pride. So Kim and I actually originally gave a version of this talk at the National Society of Genetic Counselors webinar, and that was in June, which was Pride Month. And so that brought up, the fact that we really want to honor that pride exists because of Marsha P. Johnson and because of, her being a Black, bisexual, trans woman who was a sex worker and resisted the police and did start a riot. And so, again, grounding us here today in that resistance and also acknowledging that Marsha P. Johnson was murdered and Sylvia Rivera died homeless. And so these 2 women who started the Stonewall riots, deserved better. And we know that we can't separate out struggles and identities into siloed groups. So when we're talking about gender diversity and gender liberation, we're also talking about sex worker rights, housing rights, safe communities, fighting against racism. And then really just want to ground us in the reality of today and that 23 trans folks have been murdered in the US. And so this year is actually on track to be the deadliest year for trans folks. And, we also know that our society is steeped in white supremacy, capitalism, patriarchy, and that part of the reason the binary gender system is imposed on us is because of European colonialism. So as we continue to present to you today, just really wanting to ground our presentation in the fact that gender liberation goes far beyond equality and does require a fundamental transformation of society. So to get more into the medical community, I wanted to bring up some core issues we see. So we know that medical communities are often reliant on institutions, and those institutions interface with the government, pharmaceutical companies, large corporations, and those are often the same bodies and institutions that have caused massive discrimination and violence towards the queer community. So, it's no wonder that the medical community isn't always trusted by the LGBTQIA community. And we also know that there's a history of pathologization in the medical community. So homosexuality was actually in the DSM until 1987, and gender identity disorder was in the DSM until 2013. So this is all, in stark contrast to the queer community and the fact that they celebrate self-determination and liminality. And we know that often in the medical community, we look towards the past to get evidence and to make new protocols for things. And yet the queer community in the past was largely erased. So hopefully, some of the things I raised with the trans resistance in the past is things you already knew, but if you didn't, a lot of that is because of this erasure of queer history. And so to get even a little more micro, we can see the real life healthcare disparities that the queer community is facing today. So up to 50% of gender diverse patients have to educate their healthcare provider. And there are even higher rates of, up to 50% of gender diverse patients have to educate their healthcare provider, and there are even higher rates of discrimination. And up to 20% of trans patients are actually turned away by their provider. And this is on top of the fact that there's already less access to health insurance for the queer community due to marriage or family barriers. And there's also limited to no coverage for gender affirmation, depending on the insurance in the state. And insurance often only provides coverage for things based on the sex that's listed on the insurance. So say you have a patient who is a man, but he was assigned female at birth, then insurance may not cover certain types of screening for him, depending on what his insurance is listed under. So these are just generally healthcare disparities that the queer community is facing. And sorry, I'm just seeing the chat now. So the DSM actually stands for the Diagnostic and Statistical Manual of Mental Disorders. So it's often what psychologists use to note different mental disorders. So what I was referencing the DSM to previously was that homosexuality and gender identity disorder were in the DSM, so were listed as mental health disorders. So that plus, the reason this matters for healthcare providers is that we will be seeing LGBTQIA patients, right? So regardless of where you fall in the healthcare field, you will be seeing these patients. And I include these stats for your reference, but I just want to highlight that these stats are, pretty low, and they're really underrepresenting the community. And that's because, like I said, there's this large history of erasure, but there's also a large history of violence. So thinking about hate crimes and the AIDS epidemic. So these numbers are really only reflecting those who are living, and also those who are able to share or fill out these surveys safely. So, again, take these numbers with a grain of salt, but know that you will be seeing these patients and you will have LGBTQIA folks as your colleagues. Additionally, we know as healthcare providers, we really know the importance of language and what language we use when talking to our patients and to our colleagues. And, finally, I want to talk about these two specifically genetic counseling studies. One that showed genetic counselors do have a preference for heterosexual individuals over homosexual individuals. And the other shows that less than a quarter of genetic counselors had transgender health training. So again, this is why this is important, for us to all think about and learn more about. And, I mentioned that Kim and I initially made this presentation for the Genetic Counseling Society. So when we did that, we actually surveyed gender diverse genetic counselors to ask them about their experiences in the healthcare field. So throughout the presentation, you will see quotes from different gender diverse genetic counselors. And this one I wanted to highlight here says, "Often no, I do not disclose my gender to colleagues because it means I have to do a lot of educating first, which is tiring. Not all workspaces are even safe and welcoming to non-hetero people, let alone non-cis people. So again, I just want to highlight that being inclusive isn't just for our patients, it's for us too, and it's for our colleagues and for the people you're interacting with at work and in your professional settings. And then I want to end this section with a quote from Erica Hart. So Erica Hart is a cancer survivor and a Black activist, and they say, empathy does not guarantee or assure that someone is going to care enough to do something, especially if they need a framework or a word to do it. So this quote to me feels especially pertinent to genetic counselors because we really pride ourselves on empathy and we talk about being empathetic all the time. And so I really, think this quote is resonant because it shows that we still have a lot of work to do, and it can honestly be disingenuous and sometimes dangerous to keep just saying that we're empathetic without putting in the work behind it. So next, what I'm going to do, switch gears and review some terminology just to make sure we're on the same page before we get more into the nitty-gritty medical recommendations. So first, let's talk about sex and gender. So I think a lot of folks know that gender is, an internal sense of identity. So the way somebody feels, and it can really fall anywhere. It's not restricted to a binary. So someone can identify as any gender. Ones we typically hear about are man, woman, non-binary, genderqueer, but it can really be any gender. And then sex is often an assignment made right after birth, and it's based on the external genitalia of a newborn. And it's often, classified as male, female, or intersex. However, I think this slide is really important. I want to highlight that sex is also not a binary. So I know we all know gender is not a binary, or I hope we all know gender is not a binary and we're working on that. But I also just really want to hammer in that sex is also not a binary. And I think this is especially salient as genetic providers to know. And we do know that there's a large complexity when it comes to chromosomes and genes and hormones and how they all interact. And I think this is a really great graph where you can look at, even from conception to birth to puberty, how all these different things interact can be really different for each person. And so when we say beyond the binary in the title, we don't mean just gender, we also mean sex. So really getting us to start thinking about beyond the binary in all regards. Gender diverse is a term we use a lot in this presentation. And we use it as an umbrella term to describe any gender identity that's really beyond the binary framework. Transgender, or trans for short, is a term that's used to describe someone who has a gender identity that differs from their sex assigned at birth. And I just want to make a note of, the fact that we think certain assignments at birth correlate with certain genders is a societal preconceived notion, right? So it doesn't necessarily mean that someone who's assigned male at birth has to identify as a man. That's something that we've societally assumed. And so just being mindful of that when we say, when someone is trans, that it's not their sex assigned at birth. Non-binary or genderqueer is an umbrella term often used as a gender identity for someone where they don't have a binary gender. So some people think that this means it's a person who falls right in the middle of male or female or man or woman, but really it can be anywhere. We've already said it's not a binary, so it's not this one line where someone has to be in the middle. You can really have any gender expression. And there's not one way that somebody would present or express their gender if they're not binary or genderqueer. Cisgender is a term used to describe someone whose gender identity aligns with the societal assumption of their sex assigned at birth. And then cisnormativity is the assumption that being cisgender is the norm. So assuming that everyone's cisgender unless being told otherwise. Pronouns are the words used when describing a person and often when speaking in third person. So binary pronouns are typically she, her, he, him, though, folks who are not binary could still use those pronouns. But there are lots of other different pronouns out there. Probably the most common one folks have heard is they, them. And so I also wanted to note that individuals can use a combination of pronouns. So if you look at my screen, I actually use she, they pronouns, and I put that in my Zoom name. So what that means is that if you're talking about me, then I'd like you to use she and they pronouns, which means you just switch off. It doesn't mean you use both at the same time. You can just switch off when you're saying a sentence. So, I just heard Tala speak at this conference. She was really great. They taught me a lot of new words. In my experience, though, a lot of cis folks often will just use the she because they're more familiar with it. So if somebody does, use combination pronouns or use multiple pronouns, it's a really great effort to try to use both and try to make sure you're switching off and making sure they can hear that you're aware that they're using multiple pronouns and not just falling back on the binary pronoun. Sexual orientation is who someone is attracted to. And this does not actually directly relate to gender identity. So you can have any gender identity and also have any sexual attraction. Attraction is also pretty complex. It can be sexual, romantic, or other attractions, but I'm not going to get into that today. Just wanted to note that, you can be trans and still have any sexual orientation. Okay, and last definition, I promise. Gender affirmation therapies. So these are medical interventions that gender diverse folks may choose to express their gender identity. So there are different types, like hormone therapy and surgery are probably the two most prevalent for what we're going to be talking about today. And I just want to emphasize that not everyone who's gender diverse does this. And you don't need to undergo some type of gender affirmation therapy in order to be valid in your gender. And so the graph below shows individuals who have either had, want, or do not want hormone therapy. And so you can see in that graph that it actually varies. And so we shouldn't ever assume that someone has had specific gender affirmation therapies just because of their identity.
Okay, so now I'm going to take over for a little bit. Again, hi, my name is Kim. I use she, her pronouns. Thank you so much for having me today. So we are going to touch on a lot of very specific topics to genetics. I know that we have a diverse audience in terms of what you all do, genetic counselors, geneticists, public health patients, family members, etc. So I'm hoping that some of this resonates with you in whatever you do. The first thing I'm going to talk about is pedigrees. So pedigrees are the family history tool that a lot of genetic providers use in order to document the family, using different shapes to represent people. So typically people use a square to represent a man, a circle to represent a woman. And so I wanted to talk about how we should be representing trans folks on a pedigree. These are some outdated symbols that people used to use on pedigrees that NSGC and NCCN recommended. They're outdated for a number of reasons. For example, NSGC used to recommend that we use the symbol for what the person identifies as. So if they are a woman, you use a circle. If they are a man, you use a square. And then writing karyotype underneath. So writing the sex chromosomes that we were talking about earlier underneath. This has been heavily criticized because we don't necessarily know the chromosomes of a trans person, for example. And so this was very confusing for people. NCCN is the National Cancer Comprehensive Care Network, and they had this other pedigree recommendation, which was criticized for a number of reasons, including just being confusing. But these are what we recommend and what NSGC is actually in the process of updating their pedigree symbols to be. So there was a study done by Heather Barnes et al. In 2019, and they asked trans people how they wanted to be represented on a pedigree. And this is what they said, and this is what conclusion they came to. So they recommend that you use the symbol for whatever gender the person is. So if they are a man, you use a square. So a transgender man, for example, you'd use a square, and a circle if they're a woman, a diamond if they're non-binary or genderqueer, and then writing AFAB or AMAB underneath. So if they were assigned female at birth, the sex assigned at birth if it was female, put AFAB underneath, and AMAB would be assigned male at birth, put that underneath. So this is what we recommend, as it's what was approved by the trans community, and it's what NSGC is currently updating their guidelines to be. For a lot of reasons, the pedigrees that we take are not inclusive of a lot of different types of, a lot of different family structures. And I recommend that when you take pedigrees in terms of gender and sex, that you focus on gender to really honor the person's gender. So when asking about people, asking what their genders are, and then you can preface saying, you know, if someone's gender is different than the sex assigned at birth, that might be important for our evaluation. So please let me know. One strategy I use in counseling is before I take a pedigree, I might say something like, family structures are different for a lot of different reasons, including gender diversity, same-sex couples, adoption, single parent households. So if a question I ask doesn't apply to your family or a different situation applies, please let me know. Just to recognize that for a lot of reasons, again, the pedigrees that we take are based on a lot of assumptions that we make about family structures. And when we're taking these family trees, it might be important to address privacy and confidentiality concerns of our gender diverse patients. For example, lots of gender diverse people might not want their other healthcare providers to know that they are trans or non-binary for reasons such as past discrimination, fear of future discrimination, insurance problems. So it might be important to go over who has access to this information and if they're comfortable having that in their medical record. And so now we're going to touch on some specialty-based considerations and just give you a peek on how some gender-affirming therapies or being gender diverse may impact care. So this is a quote from a study, and it says, "It is not uncommon for providers to state, 'I treat all my patients the same.' This mentality underscores the need for training because the goal of quality healthcare is for equity and not equality. The heteronormative assumptions of providers are the very reason why LGBTQI individuals do not want to be treated the same." We're going to start talking about cancer care. Cancer genetics for trans folks is something that both Tala and I have done extensive research on. If you look us up, you can find some publications related to this to further expand on what I'm going to talk about right now. But basically, both Tala and I have done studies together on specifically for cancer genetics. Are there any specific indications that might be a little bit different for gender diverse people? And a lot of these differences are related to gender affirmation therapy, because as you can imagine, things like surgeries can impact cancer risk, and things like hormones can also impact cancer risk. And so in our studies, we found that there are some unique referral indications that may or may not come up for gender diverse people that everyone should be aware of. For example, it came up that gender affirming surgery could very well be impacted by cancer genetic testing. So in cancer genetics, I'm not sure how familiar all of you are with cancer genetic testing, but basically we can do genetic testing to help figure out what someone's cancer risk is, like their risk for breast cancer, their risk for ovarian cancer, their risk for prostate cancer. And so this testing can sometimes be helpful in figuring out what surgery someone would need if they're considering gender affirming surgery. For example, some of you may be familiar with something called top surgery. That is the surgery that some transmasculine people or trans men may get to remove the breast tissue. This surgery is different than a bilateral risk-reducing mastectomy. So a bilateral risk-reducing mastectomy is a mastectomy where someone has their breast removed for the purposes of cancer risk reduction. The difference is that with top surgery, you're not removing as much tissue as you would be with a risk-reducing mastectomy. So if someone has top surgery, they might still have a residual breast cancer risk that they wouldn't have as much with a risk-reducing mastectomy. I say all this because if someone is considering gender affirming surgery and they have genetic testing and they find out they have a high chance for breast cancer, they might consider getting that bilateral mastectomy instead of the classic top surgery because a mastectomy reduces more breast tissue. So in that sense, genetic testing can change the gender affirming surgery that someone gets. There's also a concern that hormones might impact cancer risk. Most of the data we have on hormones is from cisgender people who've taken birth control, for example, but there is some data that suggests estrogen therapy could impact breast cancer risk, and testosterone could impact ovarian and endometrial cancer risk. So some providers are referring gender diverse people over to genetics because of fear of how a genetic risk might be playing a role with also having these gender affirmation hormones. So basically there's some fear of providers that if a person has a genetic cancer risk, that the providers are scared to give them these hormones. And for this reason, genetic counselors have reported that some minors who are considering hormone therapy end up in their clinics. And for anyone who's familiar with cancer genetics, we don't typically see minors in cancer genetics. We usually wait until folks are adults just because most of these cancer risks don't impact children. I'm going to touch on hormones more in a second. And finally, another theme that Tala and I have found is that insurance coverage for gender affirming therapies like hormones, like surgery is pretty bad, pretty universally bad. And so a lot of times surgeries like top surgery are viewed as elective and not covered by insurance. So sometimes trans folks were coming into clinic hoping for one of these genetic cancer risks because it might help them get insurance coverage for those surgeries. And I say hoping with these quotation marks just because they're not actually hoping for a higher cancer risk. They're hoping for insurance coverage for these necessary surgeries. And so it really shows a break in our medical system that folks are coming into our cancer centers hoping to have these pathogenic variants in BRCA, for example, which is a high chance for breast cancer, so that they can have the surgery that they need for gender affirmation. And so I think, again, that just shows a break in our medical system. Touching a little bit more on hormone implications. So basically, there's a lack of consistent guidelines or research on the impacts of hormones on cancer risk. And again, a lot of the data we have is on cisgender folks who've taken oral contraceptive pills. And so there's this fear by providers to give patients hormones if there's a genetic cancer risk. And then there's a fear from patients, transgender folks, of having their hormones taken away or not prescribed because of this hypothetical risk. And I think as providers, we can really advocate that we don't have the data to suggest that we shouldn't be prescribing hormones for people, even if they do have a high genetic cancer risk, because these hormones are very important for their well-being. There's a huge, for people who want gender affirmation, there's a really high rate of suicide for people who are not able to access the therapies that they need. And so for a lot of people, having the hormones can be a life or death situation. And we really need to take that into account versus the maybe potentially small increase in cancer that could arise from having those hormones. In terms of language to use, I think it's really good practice to degender the language we use around our organs. Organs are not inherently gendered. And so instead of saying things like female reproductive cancers, we should name the specific organs that we're referring to. So if we're talking about ovarian cancer, say ovarian cancer, prostate cancer, breast cancer, we don't have to say female reproductive, we could say ovarian or uterine or cervical. And instead of saying male and female hormones, we should be naming the specific hormones like estrogen, like testosterone. Everyone has estrogen and testosterone. They are not inherently male or female hormones. So we should just be naming the hormones that we're referring to rather than saying male hormones or female hormones. There are guidelines for screening for trans and non-binary people. They're really good guidelines by UCSF based on people's gender affirmation. So if someone's been on hormones for a certain amount of time, should they get mammograms, for example? These guidelines don't take into account genetic cancer risks, so that is a big gap there, but I would really recommend that folks who are in cancer centers take a look at these guidelines so they can become familiar with what cancer screening looks like for gender diverse people. We also show an article from the Journal of Genetic Counseling that I highly recommend. It talks about different considerations for trans people based on gender affirmation in in a genetic setting. Okay, switching gears a little, I'm going to talk about prenatal and the prenatal space. As you can imagine, the prenatal space is very gendered. A lot of times we're talking about women's health clinics. And so just coming in, our center names are not even necessarily inclusive. As shown in this quote from a gender diverse GC who filled out that survey Tala was talking about, another microaggression that comes to mind is how gendered the prenatal setting is. It's so mom and dad and baby boy and baby girl. All the forms are so cis heteronormative. It feels like an entire world in which I do not belong. And I'm sure a lot of our patients also feel the sentiment that the prenatal space often does not feel inclusive for gender diverse people, even though many gender diverse people get pregnant and have children, or their partners get pregnant and have children. There was this study done within the genetic counseling sphere, Ruderman et al. And et al. Tala and I are also on this study. So this is a shameless self-plug. But basically, there's a lot of area for improvement in how we're counseling our patients and how we can make our clinics more inclusive. For example, a lot of genetic counselors use flip books when they are describing things. And in their flip books, they might have a man and a woman and show how our genes are inherited. Those don't have to be gendered. We don't have to have a man and a woman. So take a look at your flip books and see if they are inclusive of gender diverse people. Similarly, our lab forms are often not inclusive and only have options for women to get pregnant, and talking about a pregnant woman, for example, are not including options for both sex and gender. And so I think we can really advocate to make our labs more inclusive, and I'll talk about that more too. Our intake forms, a lot of them don't have options for pronouns or to specify gender. So that is one step that we can all take in our clinics to help make things more inclusive and to help stop misgendering people. In terms of prenatal language, I'll talk about this a little bit more in a second, but there's a lot of language in the prenatal setting that is not inclusive. AMA is a common term we talk about in genetics, which is advanced maternal age. Why can't we just say the risk is people, age-related risks, for example, or advancing age? Why does it have to be maternal? Similarly, mom and dad is used a lot, women's health centers. So there are lots of inclusive options for language that we can incorporate into our appointments and into our clinics. Waiting rooms can be really uncomfortable spaces for people, especially, trans men who are pregnant. Sometimes might be overly scrutinized in a waiting room or have providers who are overly curious about their situation. And that's really inappropriate. It just further others the person. In your clinics, if you have the capacity, it's great to have a sign in your clinic waiting room saying, if you need a separate waiting space for any reason, please let the front desk know. That could be a good way for not just gender diverse people, but for other people to have a private space if they do feel like they're being overly scrutinized. For example, if someone is in, often in prenatal, we're dealing with really hard situations. Lots of people are crying in the waiting room. It would be nice just in general to have a separate waiting space for those who ask for it. That being said, I understand that some clinics do not have the clinic space to accommodate that. And so when we're thinking about language, especially in the genetic setting, instead of saying we have 2 copies of every gene, one from mom and one from dad, we can just say one from the sperm and one from the egg. Most people will understand that. And that's more inclusive terminology. Instead of assuming mom and dad, we can say parents, or sometimes donor might be appropriate. Instead of saying gender of the baby, we should be saying sex of the baby, because no prenatal screening is going to determine the gender of someone. People can not know someone's gender until they're old enough to tell us. So instead of saying gender or the gender test or anything like that, we should be saying sex. Instead of assuming someone's a husband or a wife, we should just say partner until they label the person themselves. Partner is an inclusive term for anyone. And so I think we should be using the term partner unless someone says, oh, this is my girlfriend, then you can say it's their girlfriend or something like that. Also, instead of just asking, is this your wife or is this your husband? You can say, what is your relationship to each other? Instead of saying pregnant woman, we can say pregnant person. That's very simple language we can change to make things more inclusive. And instead of saying women's health, we can say reproductive health. I wanted to touch on how gender affirmation affects pregnancy. So let's pretend we have a trans man coming to clinic who's been on testosterone. Testosterone is not a contraceptive. So people can still get pregnant while they are on testosterone, which not a lot of people realize. And so it's important that we tell our patients that if they are on testosterone, that you can still get pregnant on testosterone, though it is thought that it decreases the chance of getting pregnant. There is some evidence that suggests that testosterone could be a teratogen to pregnancies. this data is really limited. And so we don't have a lot of data on how testosterone might affect a pregnancy or a fetus. And I will say we need to balance the health of the parent to the health of the fetus, just like we do with other medications during pregnancy. A lot of people are on depression meds, for example, during pregnancy, which can potentially also be a teratogen. But we don't necessarily take the person off the depression medication because it's important to their health. And I'd say the same about testosterone. And the effects while lactating are unknown. So there's no clear evidence that someone on testosterone that would harm their breast milk, for example. For folks who've had that top surgery that I've talked about so much, it may be possible to chest feed. It may be possible to lactate. It depends on the surgery because a lot of top surgeries are done in different ways. So I'd encourage patients to discuss this with their surgeon to see if they think that lactation would be possible, but it might not be possible to tell until they try. And I'm not going to talk too much about genital surgeries, but the one thing I do want to say is that many genital surgeries wouldn't necessarily prevent someone from being pregnant, but they might necessitate a C-section. Certainly if someone's had their ovaries and uterus removed, that would prevent someone from being pregnant, but still people who've had different genital surgeries can be pregnant. And this is some language we can think about when we're talking about sex chromosome screening for X and Y chromosomes. There's a lot of prenatal genetic tests that help determine what someone's sex chromosomes look like. And I think it's important, again, to distinguish between sex and gender and avoid using terms like you're having a boy and you're having a girl, because these terms are reductive of the experience of trans folks and they're not inclusive. It's important to remind people that NIPS, non-invasive prenatal screening, can screen for sex chromosomes, but it doesn't screen for gender. So here's some language you can incorporate into your counseling. X and Y chromosomes are called sex chromosomes because they influence things like genitals, reproduction, and puberty. For example, having XX chromosomes is often associated with features of female sex, and having XY chromosomes is often associated with features of male sex. This screening can give us information about one factor that influences sex chromosomes, but there are other factors that also influence someone's sex, like hormones, the environment, other genes. For example, pictures from the ultrasound can suggest a different sex than the results of the screen. And I think it's also important to mention for intersex folks, this is more inclusive too, because sometimes there are prospective parents who get the sex chromosomes, they think they have the gender, and then they find out their child's intersex, and that's not consistent with what they learned. So we can teach them on the front end about what the sex chromosomes actually are and what they're not telling us. Okay, now for some just general recommendations for inclusivity in clinic before I pass it back to Tala. So a question that both Tala and I have got a lot is but what about liability? If I don't talk about this thing with a patient, I'm liable if I don't talk about it. And it's really important to think about for all our patients, balancing that fear of liability with respecting our patient's care and wishes. So sometimes talking about different types of cancer risk or cancer screening, like mammograms or pregnancy, can be really uncomfortable or even triggering for gender diverse people. So I'd encourage you to bring up that risk in as neutral of a way as possible. Is this something that's relevant for you? Is this something you want to talk about? Do you want to hear more about this? And if the patient doesn't, don't force that information on them. Document in the note the recommendation without using gendered language. It's really important that we prioritize rapport and respect over forced information. Forced information can be really damaging to the relationship with patients. It can make patients not want to come back to the hospital and makes it less likely that the patient will actually follow through with care that you're recommending. This is true for a lot of different aspects of how we counsel people. But so I think it's really important that we prioritize rapport and respect because it makes it more likely the patient will come back to the medical center too. And in general, we recommend that you reflect the language that patients use to describe their body parts. If they're saying chest instead of breast, use the word chest, for example. It's important that we all educate ourselves, that's why you're all at this conference, about the things that we can find on the internet and things like that. We shouldn't be relying on our patients to tell them about their medical care. Patients come to the hospital so you can give them advice on their medical care. It shouldn't be the other way around. And so it's really important that we educate ourselves as much as we can. On the same note, it's also important for us to be open to the patient's experience and expertise when they want to talk about it and if they bring it up. As we should be doing with everyone, we should explain why sensitive questions are relevant. Why are we asking about how many times someone has been pregnant, for example? That's a really sensitive question. Why are we asking about if a person has had a certain surgery? We can explain that. It's to help understand what cancer screening they need, for example. And this is just a good way to build trust. And I hate that I have to say this, but it's important that we continue to maintain good medical care and judgment. The reason I am saying that is because there are many studies that show that trans people get inadequate healthcare, even in aspects that have nothing to do with their gender affirmation. For example, a lot of trans men are denied pap smears. And if someone has a cervix, they should be getting their pap smear. And so we need to maintain good medical care and judgment for all of our patients. Test requisition forms is a common question that we get in terms of, well, what do we do with test requisition forms? And the issue with test requisition forms, or the forms that when we order a test, is that often the options for sex and gender are limited to just the sex assigned at birth. So often it'll just have male and female and no reference to gender or anything like that. And this can be really triggering for patients if they get a report back and they're a trans man and it says female on it, right? That can be damaging to the patient. On the other end, if I had a trans man and put male on the form, that might get a laboratory error if the inputted gender is not the same as the sex assigned at birth. Maybe they were looking at sex chromosomes and they say this doesn't make sense, and I'd say, well, this is a trans person. And this has happened to me multiple times where they sent back like, is there an error here? And I have to explain the situation. So we should be advocating to our genetic testing labs that these forms need to be restructured to be more inclusive. Several labs are working on this and are doing a good job. Like the lab I use for cancer genetic testing in my practice has just changed their form to include both, which I think is great. And it's an easy step to be more inclusive. It also might be important to let the labs know if the patient's insurance is under a dead name or a different name. So a dead name refers often to the name that someone was given at birth, but maybe they no longer use. And so someone's insurance might be under an old or dead name. And so it might be important to tell the labs that, just because when they're processing the insurance, it might not be under the name that you would otherwise give them. We should be asking all of our patients what their names and their pronouns are. Ideally, we'd be doing this on a clinic form. That's the easiest way, the way most people are comfortable, just writing it on a form, being able to write their pronouns. If you don't have the ability to change your clinic forms, we should be asking all our patients at the beginning of a session, not just patients that we assume are gender diverse. We cannot just identify gender diverse people by looking at them. Someone has to tell you their gender for you to know that. And if we're suggesting that we can identify trans people, that's not only offensive, but we're going to be missing a lot of people. So the way I do it is I say, my name's Kim, I use she, her pronouns, I'm a genetic counselor here. How do you introduce yourself? Or is that the name you go by? What are your pronouns? It's good practice just to be doing it for everyone. For many reasons, we might also have to be finding medical records that are under a dead name or a different name. So instead of saying, what was the name your parents gave you, or what was your old name, we can ask, do you have any medical records under a different name? Just because patients can understand that you might be needing to find some of those medical records, and that makes it very clear why you're asking. Not to mention, when we ask, is that the name you go by? A lot of people have nicknames. So in general, it's just a really great rapport building question to ask. For example, my medical record says Kimberly, and I think only my doctor calls me Kimberly. This is another one of those quotes from the gender diverse GCs that we asked, and they said, it's okay to make mistakes. We can tell the difference between someone who tries and makes a mistake versus someone who doesn't care. My final slide before I hand it back to Tala is just general environment recommendations for clinics. So we should be sure that we know where the nearest single stall bathroom or gender inclusive bathroom is. For a lot of reasons, it can be really uncomfortable for trans folks to go into the bathroom for fear of discrimination. For example, there's a lot of documented discrimination of trans folks in bathrooms, and there's those bathroom laws that are awful that you probably hear about in the news. So in our hospitals, we should be really advocating for gender inclusive bathrooms, and we should know where they are so we can point patients to them. Every patient is their own unique individual, and they have their own needs for an appointment. So being trans or gender diverse is not a monolith. We need to remember that everyone is unique in their needs, and we shouldn't just assume what someone's needs are. If you mess up with someone's names or pronouns, it's important to apologize, but apologize once and move on. Oh, so sorry. Thanks for correcting me, and moving on. Because as soon as you apologize profusely, you're not only putting, you're making it more othering and uncomfortable for that person, and you're putting the focus back on yourself. Whereas really, if we just apologize and move on, that's being respectful and not making things uncomfortable for the person. And of course, it's always great to have indications that your office is affirming, whether that be pronouns on your badges, introducing with pronouns, pronouns on your Zoom, like me and Tala have done here, trans flag pins, stickers, things like that. Those are just indications that can make people feel more comfortable.
All right, I'm just gonna wrap us up with this last section about peer inclusivity. And this is a point I noted in the beginning, but this is all really important stuff for you to know, also for your colleagues and for people in your community. This is not just for our patients. And if you think that, oh, I don't work with anyone who's queer, trans, you're probably wrong. And you probably do, and they maybe just have
Did we lose Tala?
I think so. Tala, you're frozen. So I'll just take over for a second until she gets back. So again, it's really important that we're inclusive for our peers, because we will have gender diverse peers. These are some microaggressions that people report, gender diverse people report as experiencing, saying things like, cool, you're my first trans friend, or so when are you going to really transition, or damaging things to say to people. On that same note, did you have the surgery? Or wow, I would have never known you used to be a girl, are both very othering and not appropriate things to say to people. And you might be thinking, oh, I'd never say these things to people, but we do have a list of microaggressions that gender diverse GCs reported in their workspaces. So whenever we put the onus on LGBT folks to teach their peers, you know, in a classroom setting, for example, that's inappropriate and that's a microaggression. Students come to the classroom to teach, not to be taught, not to teach. Asking inappropriate questions, like if someone's had surgery or if someone has come out to their parents or something like that, are all things that are inappropriate unless the person offers it themselves. We shouldn't be assuming anyone's gender or sexuality. We shouldn't be overemphasizing or saying you're so brave. That's very othering and can be damaging to people as well. It's important that we don't out people without their permission. For example, I'm a queer person, and I once had a supervisor from an old job tell my new supervisor at a new job that I was queer, and that was inappropriate and damaging. We don't know what kind of environment my new job was in, and that was putting me in an uncomfortable position. Again, not apologizing profusely when misgendering someone, and not saying things like, I'm sure they meant well. That's really belittling someone's experience. So if someone comes to you explaining a microaggression they experience, you shouldn't be defending the other person, saying, I'm sure they meant well, or they were coming from the right place, because again, that's invalidating that person's experience that they're trusting you with. If you're defensive when you're wrong, again, we should just apologize graciously and take the information people give us and learn from it. Dress code language can also be very non-inclusive of gender diverse folks under the guise of professionalism. For example, if you had a man who's coming in with a skirt and or a blouse or a dress, that might be against someone's dress code, and that's very cisnormative. So often dress code language is not allowing for gender diverse expression. I'll continue because I think Tala's still not here. And Tala, if you are here, please just jump in. Another one of the quotes.
I'm back.
Okay,
So
you're
sorry
back.
about that. My computer just crashed, which I didn't know was possible when you're on a desktop, but apparently is indeed possible. Great, so thank you for moving forward without me, Kim. I will just keep reading the quote. I want to tell people not to assume our gender or our sexuality, especially if we're POC, which stands for person of color, and don't fit into the stereotype of what LGBTQ plus people look like, which is often based on the white LGBTQ community. So this quote is really just, you know, highlighting that you shouldn't assume anyone's gender or sexuality based on, just what they look like. And then this quote says, "It should not always be my responsibility as a queer person to advocate for the LGBTQ plus issues in our clinic. Any provider can and should. The times when other providers have spoken up about these issues really mean a lot to me." So, you don't have to be a part of the community to really advocate for the community. And so this hopefully can empower some of you who are not a part of the community to still speak up and talk about these issues. And then we wanted to give you all some just low-hanging fruit on things you can start to do in your own practice and in your own work. So if you're ever presenting or giving a lecture or some type of webinar, make sure to think about what diversity and inclusion issues may be adjacent to your topic. So if you're giving a talk on cancer, why don't you also include a case example of someone who's trans and talking about trans folks with cancer and the issues around screening and insurance. Or if you're lecturing or giving a presentation on language issues, why don't you talk about how gendered some language can be? And, when you are including case examples and pictures, make sure your pictures are inclusive of a range of identities, and you're not just including pictures of white folks and able-bodied folks and cis folks. And then lastly, when you're meeting new students or colleagues or interns, think about sharing and asking your pronouns. Offer, if the student is queer or gender diverse, talking about if they feel comfortable discussing things with you, or identifying somebody else they can maybe go to if there's a power differential there, and having a plan to deal with what you're going to do if the student or intern or colleague does deal with some type of microaggression. And then definitely consider what are appropriate personal questions to ask someone. So, we can think about this with race when people say, like, what are you? That's clearly an inappropriate question. And similarly, you can think about this with gender. Maybe don't ask things that could be personal around that, like what surgeries have you had or things like that. And then ultimately just asking yourself, how does my lens influence how I approach the situation, and what are some things I could be missing? So I believe that's the last slide. Great. So I'm glad I got in to give those last two slides there. Yeah, I'm not sure. We only have a few minutes left for questions, but.
Thank you both. We did have some questions and comments, and some you've already responded to come into the chat. And there's some very good conversation there if anyone cares to scroll through. Amy Gaviglio had written, "You both have provided some fantastic suggestions for improving care and comfort for the LGBTQIA+ community within the healthcare setting. Are you aware of any efforts to compile these in one place as a guide for clinics and providers? Similarly, any efforts to have a place for providers to keep up to date on risks or lack thereof?" I can't see the rest of that. Medical considerations of gender affirming therapies.
Yeah, so in terms of genetics, there are not a lot of studies in the genetic counseling sphere anyway on gender diversity. I think there are maybe 6, and a lot of them have to do with pedigrees and are not as clinic focused. In terms of gender, so I mean, if you look those up, there are maybe six studies. But if you are looking up general recommendations for LGBT inclusive care, there are a couple of organizations that are really great. UCSF has a lot of really great recommendations, like I was talking about, and like local queer health centers, like the Fenway Health Center has a lot of education resources for providers on being inclusive or some of these care differences. So Fenway Health is a clinic in Boston that really focuses on queer people. Tala, I don't know if you have any other thoughts there.
Yeah, and I think just uplifting the one you already shared earlier, Kim, the UCSF cancer guidelines, again, less focused on genetics, but really great for the LGBTQIA community.
And this one you answered in the chat, but I'm not sure everyone had a chance to see it. What do you recommend as an alternative name for maternal cell contamination?
Yeah, so what I put in the chat for this one was possibly just saying parental cell contamination, or if you're talking with the person directly when you're talking about this, maybe just saying cell contamination and explaining what that means, because I'm sure most people don't even know what maternal cell contamination means. So you're going to have to explain it anyway and say, you know, some of your blood and tissue actually got mixed in with the fetal specimen. And so, you know, the cell was contaminated because of that. So again, it depends on what context you're using the word, but especially when you're speaking to a patient, I think you can easily remove maternal and just explain what you're saying.
Can you tell us more about where NSGC, ACMGG are going with recommendations for accurate pedigree representation? Are there pending organizational recommendations?
Yeah, so I think I answered this in the chat too, but NSGC does have a subgroup working on the pedigree standardization update, and that is currently under review with the Journal of Genetic Counseling. So hopefully that will come out soon, but I'm not aware of anything with ACMG, just NSGC.
Just pointing that out. Just saying. Okay. So thank you, our colleagues in genetic counseling, for leading the way there.
Another question, is dead name the term often used? Is it recommended that these medical records get linked, or is there a preference to keep them unlinked?
So dead name is a term that's colloquially used by a lot of gender diverse people, and some medical record systems do have easy way to link them or change someone's name in the medical record system. And I think that's great because we should be having those medical records for comprehensive care. So I do think they should be linked, and I do think the name should have an easy way to be updated. I know Epic at my hospital has a really comprehensive way of adding someone's gender and pronouns and changing names and things like that. I'm not sure that's true of all medical record systems, but there are ways to do it. It just sometimes when patients bounce back and forth between hospitals, things get lost.
Yeah, and I guess just to piggyback off of that, I wouldn't necessarily use the phrase dead name if you're talking to a patient. Like I wouldn't necessarily say, what's your dead name? Because I think that's probably inappropriate. That's more just a colloquial term used. I would more likely say, do you have medical records under a different name? Which again is an inclusive phrase to ask for folks who have changed their last names for many different reasons, who have changed their first names for different reasons. So again, this is increasing inclusivity for everyone.
And I will say some of the language differences, we have cisnormative language really deeply ingrained into our systems. And so not all of that language is so easy to unpack, but we need to make the effort to unpack it. Just like we unpack ableist language or racist language, we really need to make the efforts to change our cisnormative language to be more inclusive, even if it seems hard or takes a lot of practice.
Okay, well, the remaining items in the chat were comments and kind of dialogue from some of the questions that were posted. And there is a great deal of appreciation expressed to the two of you for your great presentations, it being thoughtful and helpful and informative. So unless anyone else has any questions they want to pose verbally.
Can I? I know we're getting close on time, but I'm really interested in the conversation around language. And we talked about this a little in the chat, but I think some of the recommendations that you made, aside from the challenge of breaking a habit, they're very practical and really relatively easy for people to make. But as you just mentioned now, a lot of this language around sex and gender is really deeply rooted. I can remember as early as like 7th grade biology, starting to learn about sex and chromosomes and what comes from a mom or a dad or a boy and a girl. And I'm just curious how, like, we can address this group, right? It's a group of medical professionals and stakeholders in this particular medical profession. But how do we take this conversation to I don't know, junior high school and college and medical school and genetic counseling school and all of these places where we learn this language. Like I would be very hard pressed to describe a lot of the biology that I learned around sex and cell replication and all of those things without using these types of terms. So how do we start breaking into that space? It feels like we're putting a Band-Aid on by talking to our providers. Important to do, but it still feels like a Band-Aid as opposed to going a little earlier in the system. So my question is, how do we do that? Or where do we start to do that?
And I will say,
Sorry.
I think I have really a lot of hope with kind of like Generation Z, that I feel like kids are so malleable and so accepting of other people, and it's adults who make them non-accepting or use this language. And so I love to see Gen Z's efforts in being more inclusive. And I think we have to go to teachers and we have to go to schools and teach them some of these differences, because ultimately what we're learning in schools and the language that we perpetuate can be weaponized against trans folks too, like we see in the laws against trans folks in terms of sports teams or in terms of getting access to gender affirmation. If we're saying that XY chromosomes people always have the body parts of a boy, that language will be weaponized by those lawmakers and those politicians. And so we need to be really careful about the language we use in everything we write, not just related to gender, but whenever we're talking about pregnant people, saying people, not women. So I think this conference is very cool because we have a lot of different types of employees and like a lot of different roles here. And I think we can all use that to percolate throughout our own areas to help change the language. But yeah, it's deeply rooted in our education systems, and that needs to change too.
Yeah, and hopefully, some of you like me are also, and like him, are lecturers and professors within like grad programs or undergrad programs. And so even though it's a little higher than you're referencing, hopefully it still gets it a little earlier than at this stage in the game. So again, if you're giving guest lectures and things like that, it's a really good place to highlight this stuff.
Any final questions for our presenters?
I just wanted to mention, this has been a wonderful talk. I wonder if just this talk, if this somehow could be turned into, some type of CME or something that would be available that people could bring to their group. That would be wonderful, because I could see taking this back to my clinic and saying, I think we should all, watch this together during one of our clinic meetings and kind of talk about what we can do. Maybe, I don't know if there's room to do something like that with MGN.
Yeah, I know at least for our NSGC webinar, it was recorded and it's available like on their website. But there's no like CMEs included in that. So I don't know how successful it'll be at getting people to watch it for free on their own time, but I know there's at least that.
Yeah, that's something if Kim and Tala, you are open to that, that's something we could definitely look at doing.
Sure. Yeah. Definitely.
Sorry, this is Sarah Zorin from Wisconsin. Just following up on what Jess was saying, as you were presenting, I actually emailed the director of our genetic counseling program, as well as the dean of students in our med school, who is just started an LGBTQ fellowship here at UW Health. And they're very interested in this presentation, and so I'm wondering, it is being recorded, but is it something that we can share with those groups?
Yeah. And again, there is a public, if you're talking about like genetic counseling focused people, there is a recording of a very similar lecture by NSGC already up. So if you want to share that, feel free to share it. And of course, if you, MGN, want to share it too, that's totally